So next up, we have Michael Martini, who is an MD PhD student here at Sinai. He won a doctoral thesis with distinction award for defending his thesis this year and has 55 publications over the course of his time here at Sinai. He'll be talking to us today about rescue therapy for vasospasm following aneurysmal subarachnoid hemorrhage, a propensity score-matched analysis with machine learning, which was a project he worked on with Dr. Mako and Dr. Owerman, as well as collaborators outside of Sinai.
Okay. Can everyone see my screen?
Looks good.
Okay, thank you. Good morning, everyone, and thank you for the opportunity to present my work here this morning. Before I begin, I just want to take a quick second to thank everyone, the faculty, residents, and staff for really an incredible month on service. It's really been a pleasure working with everyone. Today, I'm excited to present on some work that I performed with our department in conjunction with the Subarachnoid Hemorrhage International Trialist Collaboration, also known as SAHIT. And this will be coming out in JNS this Friday. But in particular, our work was focused on a novel analysis of rescue therapy for post-subarachnoid hemorrhage vasospasm using a combination of explainable machine learning and propensity score matching. Okay. All right, so on to some background. As we all know, SAH can be a devastating neurological condition with a long recovery. One important risk is that of a post-SAH vasospasm, which most commonly occurs between days 3 to 14 after the bleed. Of note, there's a key difference between angiographic vasospasm, which describes a transient arterial narrowing on imaging, and delayed cerebral ischemia, or DCI, which more refers to a post-SAH clinical deterioration that's not really caused by other etiologies. And in pooled analyses of SAH patients, about 43% showed signs of vasospasm on imaging, while about a third had symptoms of DCI following their bleeds. And this distinction is important because along with initial neurological condition and rebleeding, DCI, but not necessarily vasospasm, has been shown to be a top cause of morbidity and mortality after subarachnoid hemorrhage. So rescue therapies have been recommended for patients experiencing vasospasm or DCI, and they're typically classified as either interventional or non-interventional. Interventional rescue therapies, such as balloon angioplasty, typically aim to reopen the spastic artery to restore flow, whereas non-interventional therapies, such as the most commonly used triple H therapy, either aims to reduce viscosity, increase volume, increase pressure, or other parameters to generally just try to push blood across the spastic segments. And even though these treatments have been used for more than 40 years, there's relatively little evidence that they're safe and effective. And importantly, in the most recent SAH guidelines, there's actually no class 1 evidence to support rescue therapy. And this is shown over here on the right in the red boxes. And because of this, there's actually significant variability in the rescue therapy modalities and protocols that are used in centers over the world. And even the most recent RCTs in this area have failed to show an effect on outcome, including the ones listed here. And one possible reason could be that it could be non-optimized trial design as well as inclusion criteria, which could be driven by an incomplete understanding of patient and disease characteristics that could impact outcomes, leading to the inclusion of patients who might benefit less from rescue. And I'll talk about that a little bit more later. However, given these shortcomings, we sought to conduct a study with 3 goals in mind. First, we wanted to understand who's actually getting rescue therapy and what factors into the decision to give it. Second, we wanted to study patient risk factors on SAH outcomes to see which patients might benefit the most from rescue. And finally, we wanted to see if we could evaluate rescue therapy using a larger pooled sample size derived from multiple RCTs to see if we would generate any different results or new insights. So as far as our methodology goes, we derived our data from 9 mostly prospective RCTs from the SAHIT data repository. Of note, none of these studies showed a treatment effect in the original trial, and only patients with radiographic spasm or DCI who had a 3-month outcome recorded were included in our study. And this overall yielded about 1,500 patients with vasospasm or DCI. And in this study, we created individual machine learning models to predict the outcomes for each patient in our study population using over 90 variables collected from each of these trials. These things called SHAP values were calculated for each model to identify important model features and interaction effects that underlie the outcome of interest, which primarily was the Glasgow Outcome Scale score or the GOS score. And just of note, SHAP values are widely used in game theory to understand the contributions that each part of a model towards the ultimate model output, and therefore it makes it very effective for machine learning model interpretation. So I won't get into the complicated math behind their calculation, but instead one way to conceptualize them is kind of as follows. So you can imagine any type of team-based game that you want. It'll likely involve players, some set of rules that in turn result in consequences and payoffs in the game. And abstractly speaking, each player in the game may have certain skills or abilities that confer increased or decreased value to the overall outcome of the team. And in addition to their own individual value of the game, you can imagine that certain combinations of players might work better or worse together than others, which may ultimately impact the team's final result. So in the same way, we can apply these principles to medicine, whereby a patient's hospitalization is the game, the patient's characteristics are the players, the rules could be the protocols or the procedures run in the hospital, and the outcomes are basically the outcomes. So what did our study data look like? So here I've basically shown the pooled study population of patients who all had a post-SAH vasospasm and compared them based on whether or not they received rescue therapy during their hospitalization. And although there are statistically significant differences between the two, what I want to highlight here is mostly the variables that we collected, because I'll get into the analysis and the details a little bit later. But basically, we looked at demographic, physiological measures such as mean admission blood pressure and temperature. We also tracked numerous medical comorbidities, as well as baseline neurological condition at admission, details pertaining to the subarachnoid bleed, the aneurysm characteristics such as size, location, modified Fisher grade, as well as other aspects of SAH treatment. We also noted the vasospasm characteristics, as well as any neurological or medical complications that happened during the hospitalization, as well as a few details related to their ICU management, including the use of any prophylactic treatments, anticonvulsant use, or the hospital day that the vasospasm treatment was started. So with this, we'll start on some of our results on the determinants of rescue therapy. So for this, I want to start by focusing on panels D through F here, which actually show model output for predicting rescue therapy delivery in patients receiving either any form of rescue over here, interventional rescue, or non-interventional rescue. And after calculating the SHAP values for each patient in the study population, we rank them along the y-axis in each of these based on their overall model impact, which is shown on the x-axis in each plot here. And each dot within each of these plots represents a patient in the population, and the color of the dot represents the value of the feature in question. So how do we know if we can trust these numbers? Well, above here in panels A through C are the corresponding ROC curves for these respective models, which include the gradient boosting machine learning algorithm in green, which we use to make the model predictions. And we found that they were typically pretty accurate and robust in performance, evidenced by their high area under the curve, which is typically in the high 80s. And this basically means that we can trust that the SHAP values are being used to explain an accurate model, which is good because you don't want to be explaining a model that isn't very accurate. So for improved legibility, here's kind of a summary of the data from this analysis. Typically, we found that the time from bleed to admission was the most important feature for determining which patients received rescue therapy. In particular, there was a lower predicted chance of receiving it after a greater lapse time between the bleed and admission. Conversely, patients with white race, diffuse thick subarachnoid hemorrhage, and no cerebral edema typically had a higher predicted chance of receiving rescue therapy. And in comparison, the decision to administer interventional versus non-interventional rescue therapy, while we looked at it, it did depend on various patient and treatment characteristics, but we think it may actually reflect the preference of certain centers in providing this data. So from this analysis, I think there's a few interesting discussion points. The first is that the goal here was to determine factors that might influence the likelihood of an individual to receive rescue. Now, the determinant of vasospasm in each original study was ultimately the results of the investigators' opinions, taking into account all of their lab and imaging data. And this creates an optimal opportunity to understand what factors into a patient's clinical picture that might influence the clinician's decision to give rescue therapy. Our models showed that whereas SAW volume on CT scans and neurological sequelae were important factors likely to influence the decision to give rescue therapy, admission neurological condition was actually less important in predicting rescue therapy. So moving on to the next section, I'll now describe our results from a similar analysis, similar methods, this time looking at determinants of 3-month outcomes using the Gauss score, as well as determining any patient populations that may benefit more or less from rescue therapy. So in A and B, we again see that the gradient boosting algorithm yielded the best results for predicting good outcome in patients with vasospasm, shown over here in A, and as well as in a rescue therapy subset, shown just in B. So in summary table form, actually, panels C and D showed that the absence of DCI or cerebral infarction, a favorable WFNS score, as well as a younger age and a higher total GCS score on admission were actually the most important features for a greater predicted chance of a good outcome in all patients with vasospasm. The feature importance for predicting good outcome in the rescue therapy subset, however, differed with respect to a few characteristics. For example, although a lack of DCI or infarction, favorable GCS, and low age still remained important, factors such as a later postoperative day of neurological worsening and an absence of pneumonia or history of hypertension became actually very important for predicting good outcome in rescued patients. And to even better understand our data, we also made sure to explore all of the possible variable interactions, as I mentioned earlier, that could be going on in the study population using SHAP interaction values. And in doing so, we found that some of the strongest interactions we saw were actually noted with age, which form interesting relationships with GCS verbal scores, shown on the left, as well as midline shift on the right. In particular, you can see here on the left that age and a normal GCS score, shown in red, interacted such that having a normal verbal score at an older age was far more important for predicting good outcome than having a normal GCS score at a younger age. This is shown as the red dots are kind of trending up here. And similarly, age and midline shift interaction such that having a midline shift, also shown in red, resulted in a much worse predicted outcome if the patient was also elderly compared to if this midline shift was present in a younger patient. And this is shown as the red dots here kind of trending downward. And together, this all suggests that age is a really important variable to consider, giving its modulatory effects on the importance of other clinical factors. But what insights can we glean from this analysis? I'd say that perhaps most clearly, we found that the presence of DCI and infarction was the most important feature influencing 3-month Gauss scores, regardless of rescue therapy status. And actually previous studies, including this one published in Stroke, have also shown that the combination of DCI and infarction correlates more strongly with poor outcome than vasospasm. And that's kind of shown here, highlighted in this red box. And I think that this actually kind of confirms that our approach seems to produce relatively valid results. We also found that the absence of certain patient comorbidities and complications, such as most notably hypertension and pneumonia, actually became much more important predictors of good outcome, specifically in patients treated with rescue therapy. And there's also precedent for this in the literature. However, these findings, I think, could also reflect potentially a greater comorbidity burden in these patients who have hypertension or end up with pneumonia, or even some sort of possible interaction with rescue therapy. For example, induced hypertension or hypervolemia could potentially predispose to other complications listed here. And they might be particularly bad in those with hypertensive histories or decreased pulmonary capacities. So moving on to the final goal of the study, at this point you might be saying, but Michael, of course, there's going to be variables associated with good and bad outcomes after rescue therapy. And that's cute that you can rank them like this, but what about the state of rescue therapy as it stands? Can you evaluate that with this large data set without too much bias from confounding variables? And I believe the answer is yes. We can use propensity score matching to simulate prospective study allocation and control for factors that may bias an individual's allocation to either the treatment or the control rescue group. And this is a pretty routinely used method in the literature, actually, to mitigate the effects of uncontrolled confounding variables. Basically, propensity score matching accounts for the covariates that may predict receiving treatment and helps to reduce confounding by enabling one-to-one matching to control for these variables. But the question is, how do we know which factors might be influential for rescue therapy allocation in our data set? Well, that's an easy answer. We can actually use the factors that we identified earlier for predicting the decision to administer rescue therapy. So that's what we did. And in the end, our propensity score model ended up controlling for these variables shown here, which our machine learning models told us were the most critical. And importantly, from our large starting sample size, we were actually able to match 385 pairs of patients with vasospasm by their rescue therapy status on each of these variables that may have influenced rescue therapy allocation for our own internal analysis. And when we look at the results from the matched cohort analysis, we see that the rescue therapy doesn't significantly increase the odds of an excellent outcome, which we defined as a 3-month GOS of 5, which corresponds roughly to only minor functional deficits. However, below you can see that it actually does increase the odds of a good outcome, which we defined as a score of 4 or 5, which correspond, and a 4, for example, corresponds to a moderate deficit, but no functional or no assistance is needed in everyday living. So to conclude, I think here are some takeaways from this analysis. Most notably, our data does support the use of rescue therapy. And this is important because, as noted in the beginning, the existing evidence in the field kind of suggests that rescue therapies can reduce vasospasm, but are yet to improve clinical outcomes. And some of the reasons for this discrepancy could be that we conducted a pooled analysis involving many more patients, allowing us to potentially detect a smaller effect size. And in addition, as I say at the beginning, previous studies in the field may not have had optimal designs or inclusion criteria to properly assess efficacy in the right patient population. So this begs the question of whether we can do better. And I think that our machine learning analyses do offer a few useful suggestions to do better in the future. First, I think that our findings suggested that DCI and infarction are the most important events to target and prevent in SAW management because they're invariably linked to poor outcome. And trials specifically focusing on intervention in patients with DCI infarction should therefore be able to show, I think, the most significant improvements in clinical outcomes. Second, our analyses also showed that additional monitoring of patients with hypertensive histories and prevention of new onset pneumonia may be something to target to further improve outcomes in rescue patients. And finally, the strong negative interaction effects observed between old age, low GCS verbal scores, and midline shift, leading to worsened outcomes, also suggest room for clinical benefit in patients with these combinations of characteristics. So I think that further investigation of these points in well-designed RCTs may lead to a shift in our ability to ultimately recommend more consistent rescue therapy protocols for specific patient populations. And just quickly, I think it's always important to mention limitations. So for this study, some of the included RCTs had defined inclusion criteria that could limit external generalizability. Some of the factors that were important for some of our outcomes may not have been detected because they weren't included in the data sets. Also of note, our findings are associational, not causational. And finally, the treatment biases may actually still exist despite propensity score matching, as it doesn't fully substitute for a prospective RCT. And finally, I want to thank all of the people who made this work possible, including the International SAH collaboration led by Dr. Locke McDonald. I just want to thank the Mount Sinai Neurosurgery Department for putting on a fantastic rotation. And I also want to thank the MSTP leadership and the funding I've received for my training. Thank you for your attention. I'll take any questions.
Thank you, Michael. Do we have any questions?
That was really superb. I have a question. Can you separate which type of rescue therapy contributed to that improved GOS for
the Glasgow outcome score? Yeah, so we actually did do that sub-analysis. I omitted it here just for the sake of time. I would say, so when we did that analysis, we did find that some of the factors that were important for predicting the GOS outcome Again, they did differ between the non-interventional and the interventional rescue therapies. And again, I think some of that may have to go back to the mechanism of the treatment that's being done. I think one example was that the non-interventional rescue therapies, such as the Triple H therapy, wasn't as effective in patients with cerebral edema, and that might just be because, one of the aspects of Triple H therapy, hypervolemia, you might be flooding the body with excess fluid, which might potentially worsen some of the cerebral edema. So those are some of the things that you might potentially consider, I guess, in future studies, looking at which patient populations to kind of match to which rescue therapy. Does that answer your question?
Well, you divided them into medical versus interventional. I was just wondering if the improved outcome broke down along those.
Oh, for the odds ratio.
400 patients who did better with GLS4.
Right. So so we didn't actually look at the Glasgow outcome score odds ratio at 3 months between interventional and non-interventional, but that's absolutely something that we should look at later. I think we were mostly focused on trying to show, like, the answer to the bigger binary question of does rescue therapy work or not. But I totally agree. We should look at the individual types later.
Thank you.
Dr. Lay had a question or a comment as well.
Yeah, hi, Michael. Thanks for the talk. In the ICU, one of the things we notice is that the decision for rescue therapy is often a discussion based on the change in exam. And I wonder if there's any way to integrate the dynamic sort of ICU course of the patient, namely the exam change and the timing difference between the exam change and the performance of rescue therapy. Do you think the database would allow that type of fine-grained sort of analysis? Because I think that's what we see on the ground.
Yeah, no, exactly. I think you're absolutely right. And that was something that I think was also a limitation that's worth pointing out in this study as well. So these were our study databases were mostly RCTs, just looking at various interventions in subarachnoid hemorrhage, not necessarily looking at vasospasm. A lot of these 9 included studies were included because they looked at vasospasm, whereas some of the SAH databases did not. And unfortunately, they're just previously published RCTs. They don't include a whole lot of data regarding the timing and, as you mentioned, all of those factors and that factor into the real-time decision making. I think potentially gathering a prospectively collected data set from multiple centers could be worthwhile in this sense, and including some of the more granular details that you mentioned, because I do think that's very important. We kind of tried to infer some of that a little bit, the clinical decision making from the machine learning analyses that we had here, because ultimately the call for vasospasm, clinicians will review the lab data, the imaging data, and just discuss whether or not they want to give rescue therapy then and there in the ICU. But that was kind of the best that we could do from here, was whether or not a patient ultimately did end up receiving rescue therapy, and kind of retrospectively looking back and saying, does that make sense, and why was that the case?
All right, I think we have to move on because of time. Thank you, Michael, for that presentation.
Thank you.